What if you didn't know what you thought you knew? And what if everything you thought you knew was all wrong? You must first understand the real truth and underlying cause of a problem before you can develop a total solution. Join Dr. Jerry Katzman right here on webtalkradio.net each week and hear from the innovators in the worlds of science, health, and medicine. Join the conversation on Facebook /Healthy Strong Active. Here is Dr. Katzman.
Welcome. Again, we're going to have a great show today because I have the pioneers in medicine, as I've tried to bring that week by week to everybody. But today is going to be a little bit different because, as you know, I'm an ophthalmologist by specialty, and what I need to do is I need to look in your eyes in the smallest organ to discover things about your body. But in this particular case, we're going to look at the body's largest organ, which is the skin. And basically, there's so much to learn from the skin, but you have the advantage because you can examine yourself and find things to bring it to someone's attention and could be life-saving in many respects. So it's a really important discussion we're going to have today. And my guest is a luminary, a pioneer in the field of dermatology. I mean, if I go through his resume, you'd be amazed. But to start with, he's an associate clinical professor at dermatology at Mount Sinai. He's the co-director of their Dermatological Cosmetic Surgery Program. I mean, he's also on the Medical Advisory Board of basically HealthyAging. And on top of that, I mean, he's on the Medical Council of the Skin Cancer Foundation. But, you know, he's involved. He's trained in New York, and I'm going to ask these questions anyway. But he was even the past president of the Dermatological Society in Greater New York, and he's lectured nationally, internationally. I mean, I'll just say this about him. He's listed in who's who in medicine and healthcare, who's who in science and engineering, and who's who in America and who's who in the world. I mean, if that doesn't tell you who I have as a guest, nothing will. So my guest is Dr. Albert Lefkovits M.D. Dr. Lefkovits, are you there?
Yes, I am, and thank you so much for your very flattering introduction.
Well, I want to make this as informal as possible, and in doing so, may I call you Albert?
Of course.
You know, as I was saying at the onset, now, as an ophthalmologist, my role is to take the smallest organ in the body and look in the eye and discover things, and, you know, there's syndromes and disorders that most people would never think about. But in dermatology, it's really most overlooked specialty because, you know, people think about bruises and bumps and those kinds of things, but don't realize that they have an opportunity to examine themselves and prevent so many disorders and diseases by early diagnosis. And so it's so critically important for people to be aware of dermatology and why it's important to go to a dermatologist who knows what they're doing and who basically is not only a pioneer in the field, but has all the latest detection devices and is up on the technology itself. So having said that part of it, just give a brief background yourself, concerning yourself in dermatology.
Well, of course, you've given a nice resume of my professional career, but the thing that distinguishes our practice is that most dermatologists are either medical or cosmetic dermatologists. And in our practice, we do a lot of cosmetic dermatology with lasers, Botox, fillers, and so forth, but I also enjoy treating people with serious systemic diseases. And as you pointed out, the skin is indeed the largest organ of the body, and as such, it reflects the general health of the body. And because it does reflect the general health of the body, we're able to, by looking carefully at a patient, get indicators, for example, of whether somebody is likely to have diabetes, even anemia, heart disease, and various cancers. And the beauty of dermatology is not only can you see this as a wonderful window into the body, but it gives us an opportunity to educate people about taking care of themselves, and therefore to, in a very intelligent way, to slow down the aging process. And of course, as dermatologists, we do emphasize the need to use sunscreen. And May, in fact, is officially designated as Melanoma Detection Month by the American Academy of Dermatology, the Skin Cancer Foundation, and the American Cancer Society. And I feel that everybody should have an annual total skin examination by a qualified dermatologist, because malignant melanoma has a very high death rate, but if discovered early, can usually be cured easily.
Well, in keeping to that, and we're going to get into this thing with melanoma because it's at the other end of the spectrum, skin cancer. I was really stunned to learn and know this, that, for all cancers, essentially in young women, melanoma is one of the leading causes of cancer. I mean, it's behind breast cancer, obviously, for disease in the breast, but for young adults, young women, I was stunned to believe that really was. It's more prevalent in women than anyone else.
Well, of course, skin cancer is the most common cancer of the human body. But most skin cancer, such as basal cell, is not fatal unless it's really been woefully ignored. On the other hand, malignant melanoma is a leading cause of death of people in their 20s, their 30s, and ironically, the rate increases as people age. And not only that, there's a big genetic factor in melanoma, and anybody having been diagnosed with melanoma should have his parents, children, and at least his relatives seen by a dermatologist because the familial incidence is so strong. Now, the other thing is, the other types of skin cancer are directly related to sun exposure. And sun exposure can change a benign nevus, benign dysplastic junctional nevus, into a melanoma, but many melanomas arise in areas never exposed to the sun, and even internally from the respiratory tract and so forth. So this is something that we should always be vigilant about, and to try to have it diagnosed at the earliest possible stage.
Well, the statistics, there's over 70,000 people a year who are diagnosed with melanoma, which is astounding. And on top of that, the incidence, the rates we're talking about are almost 10% a year of people who, again, which ordinarily, and we'll talk about prevention and detection, but could be prevented because it's increasing at about 2-3% a year in terms of the death rate relative to that.
Well, the reason for that is people have more leisure time, they're out in the sun more. Now, basal and squamous cell carcinomas are found in people who are in the sun all the time, like farmers, sportsmen, and so forth. Melanomas, though, are more likely to occur in people who get brief but very intense sun exposures. For example, people with Nordic or Celtic skin going down to Florida, going down to the Caribbean, not using sun protection, and getting intense bursts of ultraviolet radiation. And particularly people with blue eyes, blonde or red hair, and fair skin should be very diligent in applying sunscreen with a minimum SPF of at least 30, maybe even 50, wearing a hat, taking particular care to protect their ears. And as men age and lose hair, they lose any natural protection from their hair. And I see a lot of people in their 70s and 80s who develop multiple squamous cell carcinomas on the scalp. So sun protection really should start at an early age. Start with your children, wearing good clothing, hats with wide brims. And it's also important to wear sunglasses with UVA and UVB blockers, because the same sun that damages the skin from my perspective will damage the eyes from your perspective. And as you know, if you protect the eyes from the sun, you lower the incidence of cataract formation, and I would assume you're more of an expert than I am on factors such as macular degeneration and other diseases of the eye.
Yeah, no question about that. It's so important. And we should note also that, in terms of the incidence, that, Hispanics and blacks, although one would consider they have less of an incidence, they have pigmented skin, but they tend to get, melanoma on their hands and feet, or their more hidden areas. And so it's so important for them to also go to a dermatologist and have examination, because they wouldn't be thinking about it. These are areas that are not exposed to the sun that are susceptible to melanoma.
Well, not only that, if somebody with black or dark skin sees darkening under the fingernails, that should certainly mean an immediate dermatological consultation, because melanoma of the extremities tends to be particularly aggressive.
Oh, absolutely important that way. Now, one of the things about yourself is you were the first practice, I think, Max 3. It's a dermoscopy, and you can explain what that is. And you have some type of digital device that really makes the precursors to cancer evidence so that people could prevent these things in advance.
In the last decade or so, the use of dermoscopy has gained in popularity. It was introduced in Europe, where it's almost universally used, and the last 2 or 3 years has become introduced into residency programs all over the country. And basically what dermoscopy does, in the MolMax there are 2 camera sets, one of which takes pictures of large areas of the body, so you can tell whether a lesion had been there before or not, because very often people are confused in how long a lesion had been present. But it also uses generally a microscope with low magnification, perhaps 30 times, but it can go up to 100 times. And that enables you to look at the structure of the pigmented lesions. It doesn't show you the cells, but it does show you the structural patterns. And by looking at the structural patterns, you can make, with a very high degree of precision, a diagnosis on whether a lesion is likely to be benign or to be a malignant lesion or a very dysplastic lesion with the potential to go into malignancy. More recently, another technique called laser confocal microscopy has been introduced, which allows you to see the cells itself. But this is being much newer in development, has not had too much in the sense of widespread introduction. But that offers us great promise to further refine and give us more precise methods of diagnosis. So if you do that, on the one hand, you can obviate the need for biopsies. So you can eliminate unnecessary biopsies. And on the other hand, it can help us find out those lesions that are more likely to be a problem. Some people have a syndrome called the dysplastic mole syndrome, where they could have 40 or 50 or 100 or more than 100 moles all over the body. When people have that many moles, it becomes a challenge to decide which lesions you biopsy and which you leave alone, because particularly if you have these all over the body of a young person, particularly a young woman, you don't want to cause any unnecessary scarring. So the use of these 2 modalities will be very helpful in management of lesions of that sort.
Well, so the concept is one thing. Patients need to at least examine themselves, you'd say once a month at least, and just try to do, and of course they can't be as complete as having someone fully examine them as a dermatologist, but at a minimum they can just look and see if there's any freckles, bumps, lumps, anything unusual, anything new, anything that's been there for long periods of time, so it can be documented and it can be followed and watched. That's take-home message with that. But having said that, with the new technology, and certainly the technology that you have, or people, in my practice, again, we started out where we'd see a freckle around the eye, and we'd use a camera, and we would obviously try to, we'd measure it as best we could. We didn't have the same as a dermoscope. Of course, today it's even more sophisticated. We have tools, but we didn't have that. But, with that, you're able to, as you say, eliminate the need for biopsy possibly, and lower the incidence. Again, if melanoma is growing at almost 3% a year, with 10% of the population, 7,000 people dying from melanoma, the fact is, if it just takes observation and getting to a doctor, it becomes curative if you get to it. It's what a message to get across, and I didn't realize it was melanoma month. It just makes it even better to even talk about this.
To add to your message, it's normal for people to develop new moles up to the age of 40. However, if you see a mole developing after the age of 40, that's unusual. And I think the burden is to prove that that is a benign lesion. Any mole starting after the age of 40 has to be examined very carefully and has to be suspect of possibly being a melanoma. In addition to that, with pre-existing lesions, the rules put out many years ago by the American Cancer Society and the Skin Cancer Foundation persist. If you see any change in a pre-existing mole in the sense of it growing or changing color, that should be brought to a doctor's attention. Now, there are also two other signs we go by. One is called the American flag sign. So if you see a mole that has the colors of red, white, and blue, as we have in the American flag, that mole has to be looked at very carefully, because that automatically has to be suspect of being a melanoma. In addition to this, if you have a person with lots of moles and one sticks out to you like an ugly duckling, that's called the ugly duckling sign, because if you have one mole in a whole field that's so unusual, that means that that mole has to be examined carefully.
Right. Well, again, I think the importance here, that take-home message, that self-awareness is so important. And what people probably don't realize is that in those areas of the body that are not exposed to sunlight, in the groin area, in the rectal area, under the feet and the hands, and sometimes I'm sure they may not be comfortable just going to that kind of a doctor. I tell people out there that if that's the case, at least go to your gynecologist or to some specialist to look at it. So if a referral needs to be made to a dermatologist, they can do so. But someone needs to look at it, because most patients won't be able to observe it or wouldn't even be thinking about it along those, or they may be embarrassed to talk about it or even to go somewhere about it.
That's a very good point you make. Normally, if I see a female patient, particularly for the first time, I will ask her if she's seen her gynecologist recently. And if so, I think I can usually depend on the gynecologist to alert her as to whether a lesion should be evaluated. Because obviously, many people are reluctant when they first meet a new doctor to have those private areas examined. And for the same reason, some men are self-conscious when they're being examined by women, although I think that men are more comfortable being examined by women as more and more women have entered the medical field.
No question. By the way, I just want to remind everyone, you're listening to Healthy, Strong, and Active, Your Strategy for Life, and my guest is a pioneer in the field of dermatology. Dr. Albert Lefkovits has offices on Park Avenue in New York, and we're having a tremendous conversation here because it turned out to be Melanoma Week. I wasn't aware of that, and the fact is we're having a conversation about prevention, and melanoma is a serious, serious cancer that causes nearly 7,000 to 8,000 deaths a year. And it's on the rise, and it's mostly an older generation now, although you see it in young women. But the fact is, at this point,
and in young men also,
and in young men, the key to really cure is early detection, both to have it observed by yourself, second by a professional, and then documented with instrumentation so that your doctor has what's necessary to be able to do something. And that may eliminate the need for biopsy and may be completely 100% curative. So the message cannot be said more than enough. There's a life-saving message here with respect to that, without question. I'll ask you this, but for someone who does have melanoma, there are some drugs though that are not only in research and development now, which show some promise, but there are some mechanisms of action of current medications that could be used either individually or in combination, like a vaccination form that has some benefit in turning off the genetic form. Maybe you can talk a little bit about that.
Well, we don't yet have an effective melanoma vaccine. However, the progress in treating human cancer, not just melanoma, but many other forms of cancer, has become absolutely revolutionized in the last 2 years. You have a group of drugs called immunomodulators that affect the immune system, biological agents, new chemical agents, and in fact, years ago, we used to speak about treating breast cancer, lung cancer, skin cancer. But the treatment of cancer today has evolved and progressed to the standpoint where we look at the genetics of disease, a new field called the epigenetics, and the molecular mechanisms. So this has given us the realization that you can use a whole variety of anti-cancer agents against a large variety of tumors. In the case of melanoma, I don't think we've yet achieved a cure through chemotherapy, but we certainly have been able to extend the period of remission being free of disease for a much longer period. And these changes have been remarkable and revolutionary. So this really gives new hope to patients not only with melanoma, but cancer. And this, of course, is something that you should discuss with your doctor or an oncologist or an oncological surgeon, because the hope is there. Now, not only that, but if you can extend the lifespan of somebody by 2 years, with a rapid progress being made, it may be that by giving that 2 extra years, that within that time period, a cure will be found. Now, the late great actress Elizabeth Taylor, early in her youth, had a form of pneumonia, and just at that time, a new drug had been developed to treat staphylococcal infections, and that saved her life, whereas 6 months before, she would have died from that, or even diabetes. There was a discovery of insulin by Banting and Best in the 1930s. Before that time, the treatment of diabetes was extremely harsh, extremely primitive. So you never know when these efforts of investigation of cancer come to fruition. And for that reason, even people with fairly advanced stages of cancer can have a realistic base for optimism.
So there's, without question, saving lives, no matter what the extent of timing, can mean everything because of the evolution of disease and because of how science is rapidly moving to these new curative states.
However, with any form of cancer, melanoma, breast cancer, colon cancer, the earlier the diagnosis is made, the greater is the chance for a complete cure. You want to try to find the disease before it's spread beyond the margin of the initial tumor. And for that reason, I think that your listeners should speak to their doctors, find out their recommendations for when they should have colonoscopies, breast examinations, when they should see their gynecologist for examinations of their ovaries, genitals, and so forth. Again, although these cures are fantastic, prevention and early detection of disease all across the field of cancer still remains of primary importance.
No question. In kind of moving along a little bit into another area, what are your thoughts? I mean, there's a lot of controversy going on about essentially xenoestrogens or xenohormones, the fact that you have these various lipsticks and cosmetics, they're filled with estrogen stimulators having impact on the hormones in the body itself and the impact on the skin. What is your take on that? Relative to again, toxins and the various hormones within these cosmetics?
So topical estrogens have been around for a long period of time. There used to be, years ago, a push to use bee pollen and so on and so forth. And I don't think that very much is known about it. However, there's a large class of breast tumors in women where these tumors have estrogen receptors. And it would seem to me, without my being an expert in the field, that if you're going to apply enough estrogen, whether it's a xenoestrogen or a plant estrogen, that if a woman has an estrogen receptor breast cancer, you would want to avoid any kind of estrogens. Now, estrogens keep the body young. There's no question. When women enter menopause, there's been a controversy for years whether to use hormone replacement therapy. And if women do take hormone replacement therapy, it's going to make them feel younger, it's going to keep their bones younger, they'll feel better about themselves. And for many women, where there's no family history of estrogen receptor breast cancer, this may be an acceptable therapy. But you should discuss it with your doctor or with your gynecologist. Now, some gynecologists feel that under no circumstances should a woman use estrogens of any sort. On the other hand, there are many gynecologists who will feel that in a woman without that history of estrogen receptor breast cancer in their family, that taking estrogens, the hormone replacement therapy, does more good than harm. There are other studies from year to year. The findings change about the effect of estrogens on heart disease and stroke. And this is a very complicated subject, best discussed with your doctor, because we can't really cover all of these aspects in a phone interview.
Oh, and of course. But with respect, for example, with children, though, that end up taking, many shampoos that have toxins in them, or, again, various chemicals that act as a form of either estrogen in children, causing precocious puberty or things like that. You come across that in your practice in discussing that aspect?
Well, it hasn't arisen too much, but it makes sense that when a new chemical is introduced, it really takes at least one generation to know what the effect of that chemical is going to be. Now, for example, I can remember as a child, my mother would take me to a shoe store where to make sure the shoes fit, you would be examined under a fluoroscope to see how the toes move. Now we know that that can cause cancer. Similarly, in past years, X-rays were used to treat acne, and now I see a lot of patients who have, without exaggeration, 50 or 100 skin tumors on their face because of that, and that at one time was considered to be the best form of treatment for acne. And just yesterday, I read in the paper of people who go to a laser clinic, which has become a national chain, called Skin Laundry, where people get laser treatments 2 and 3 times a week. They buy a series of it. They feel great about themselves. They look young, which is all very interesting, except even in lasers. Now, lasers have been proven to be safe, but remember, most lasers that use heat energy stimulate collagen formation. And if you're going to use it indiscriminately, you really don't know for many years what this practice of getting lasers 3 times a week is going to result in 20 or 30 years from today. So I think whenever you get any kind of treatment, you want to be sure you're going to a doctor rather than just a commercial exercise where people are interested in how much money is being made. I can remember when the skin tanning parlors started going off in business, I met somebody who told me he was opening them up in New York and California, and I said, well, you're going to cause skin cancer. And his answer is, well, let's see who'll make more money, you or me. And he, of course, made more money until we realized how many people going to skin tanning parlors develop premature aging of the skin cancers of all sorts, and melanoma. And there's a very vigorous campaign, which has been successful in many states, to totally outlaw tanning parlors. That used to be the big fad. Now people, fortunately, are often using artificial tanners. But a lot of these things that are the fads of the moment can cause unexpected damage years later. Remember, these are commercial enterprises. People who are in commercial enterprises are in business to make money, not to help their clients. So before embarking on any new therapy, at least speak to some qualified physician who's affiliated with it, so at least you know if you're putting your life at risk, at least be aware of what you're doing and get the right information.
Well, yeah, and that's a great point, which in talking about melanoma, the fact is that they have a much higher incidence if they go to these tanning beds, and some of these young people, they're going to these tanning beds a couple of days a week. They're setting themselves up for some serious problems. And they get a higher incidence of melanoma, clearly.
I have 3 patients, each of whom, in their 30s, developed multiple melanomas, who would go to the tanning beds 3 times a week, because they like the way the tan looked.
It's the emotional content of people, they're not realizing the damage that they could do and they would do to themselves. It could be life-threatening to be aware of that. Well, this is really fascinating. There's so many topics to cover with you, and I have a lot. I'm kind of taking them as we're moving forward, so don't mind when I'm switching around a little bit as we go from one to the next. One of the areas, of course, of your expertise is you're affiliated at Mount Sinai, and it's certainly in the cosmetic surgery program. So you're in dermatological cosmetic surgery, and you're one of the experts in the healthy aging with respect to using Botox. And I think you're one of the first also dermatologists use, I think, the N-light laser, to remove surface wrinkles and what people want to look rejuvenated, look young, and for the necks and things as well. And I'm sure that's a booming industry, to say the least. But in your particular hands in your practice, I think you actually instruct people on the use of Botox. Now, you comment a little bit about that.
Well, the cosmetic use of Botox was actually discovered by an ophthalmologist in Vancouver, British Columbia, by the name of Dr. Jean Carruthers, who's an ophthalmologist, and her husband, Alistair Carruthers, is a dermatologist. These are outstanding physicians, and Dr. Jean Carruthers realized that Botox was used to correct disorders of the eye muscles in children. And she had the insight to realize that if this can be used to treat eye muscles, it can be used to treat facial muscles. And that's how the cosmetic use of Botox originated. Now, Botox really has a lot of medical, non-cosmetic uses. On a vanity basis, it's very effective to stop axillary hyperhidrosis, which means excessive sweating in the armpits. And for many people, this is a life-changing experience. But Botox is also used for people with bladder disorders, all kinds of muscular disorders. There's a very, very wide variety of medical uses for Botox. So like anything else, if used properly, it's really a wonderful tool. Now, some people want to be able to maintain their facial expressions. For example, if you're a TV commentator or a psychologist or a politician, you want to be able to express your face. So you want to retain the ability to have these expressions. On the other hand, some people like their face to look as though you just took an iron. So it's a matter of personal taste of the patient and the skill and expertise of the person administering these injectables.
Well, clearly we've made great headway with Restylane and its beneficial effects. I use, in cataract surgery, we were using Helon, which again precursors of this in the very, very beginning, because it also worked as a filler within the eye itself, and it was somewhat related. So the fact that Botox is another offshoot of how this technology started evolving was really, really amazing. And it's come into a certain industry. It's been used in a lot of different areas as well. But walk me through, though, a typical patient. Will come to you and how you would evaluate them for the use. I mean, for example, some people want it for the furrows between their eyebrows. Some people want it for the deep sulci around their mouths, the frown lines. I mean, what's the most common complaint someone would come into your office on?
Well, the part where it's used most, and the first part to be approved by the FDA, is the so-called glabellar area of the face. But the glabellar area is the area between the foreheads and at the top of the nose and the center of the forehead. Lines on the face start out as lines of motion called kinetic lines. And kinetic lines are due to the effect of the pull of muscles on the skin, giving rise to the lines of expression that we see. As these kinetic lines continue to develop and recur, over a period of time, the direction of growth of the collagen fibers is altered, and eventually become permanent or static lines. For this reason, the earlier you give Botox, the less is the chance that a person will develop severe permanent lines. The question then becomes at what age you start giving it. Because one of the things that I'm afraid of with many of my patients is that patients will like it so much that they become habituated or even addicted to it. So I don't like starting it on patients, particularly women, at too young an age. On the other hand, if you start it, as I said earlier, rather than later, then the patient will have less lines. But at the same time, in order to keep your skin looking youthful and having less lines, you want to be very careful to use sunscreens at all times, because the other aging effect has nothing to do with muscular motion, but rather when you're exposed to ultraviolet light, particularly the long-wave ultraviolet A, that light damages the elastic tissue of the skin. And it's the elastic tissue of the skin that holds the skin tight. So if you want to look young longer, you have to be really very conscious and conscientious in using proper sunscreen. One thing that people don't realize is that ultraviolet A radiation penetrates window glass. So if you're sitting in front of a window, or even if you're driving, even if you have a tinted window, the ultraviolet A can penetrate that glass. So when you go out for your car in the summertime, particularly if you live in a southern area, or on top of a mountain at a high altitude where you don't have atmospheric filtration of ultraviolet light, you have to be extremely zealous and conscientious in using your sunscreen. Now, an interesting point had brought up that if people use too much sunscreen, they may not get enough sun to have sufficient vitamin D. And vitamin D is very important to help prevent colon cancer, maybe heart disease, a lot of functions, bone integrity, and so forth. And there are a lot of people in this country who are vitamin D deficient. For this reason, you should speak to your physician about doing a vitamin D level determination on your blood. Most experts in the field recommend that most adults have a daily intake of 2,000 international units of vitamin D a day. So it's safe to use sunscreen and then to supplement your vitamin D by taking a pill of 2,000 international units a day.
I've had I've had quite a number of shows discussing vitamin D, and at length we talked about the fact of the replenishment of being in the sun. But the minimum requirement they have is about 2,000. But in my practice and in reality, it's actually they could take even a much higher amount than that if they're deficient. If they're not deficient, again, they need to discuss this with their doctors to see and get a level. But vitamin D is so important because it is associated with many diseases, to say the least, not only cancer. So that's a great recommendation.
Now, on the other hand, you don't want to overdose, because if you take too much, there are a lot of bad effects.
Yeah, no, certainly. So in keeping with this, with the Botox as well, so you have other alternatives, though. You have this N-light laser that can remove wrinkles, for example. If you were to do that in lieu of Botox or in combination with Botox, again, what's the effect of the laser relative to Botox? Can it replace it by keeping the furrows very light before they develop and not need Botox, or would one supplant the other?
So they work through different mechanisms. As I mentioned, the Botox works on weakening the muscles that draw the skin into wrinkles. Lasers have nothing at all to do with the muscular action. Lasers will produce collagen, which builds up the thickness of the skin. So they work in ways to complement one another. And again, I'm being repetitive, but you have to use sunscreen, so you cut out the ultraviolet rays. So you use all three in an intelligent way, and you try not to become too addicted to lasers and to Botox. And I say this as a person who uses a lot of Botox and a lot of lasers, but you want somebody who's going to be well-informed and very conscientious in treating you with a proper degree, rather than somebody who's just going to see you as a cash cow.
Absolutely. What age, what would be the youngest age that you would see a patient that would be amenable to a possible Botox treatment? So I'm not talking about patients that have deviations in their eyes, obviously, that it's used therapeutically. But again, from a cosmetic point of view, a young woman, does she have to be in her 20s and 30s? Later than that? What are the earliest patients from age that you would see?
Well, you really have to do it on a totally individual basis. You have to consider the physical appearance of the patient. You have to consider her emotional makeup. You have to consider her needs. I would say, as a rule of thumb, possibly in the late 20s. Now, if somebody is an actress, she may want to look younger longer, and you may want to consider doing it a little bit earlier than that. I myself would not go to somebody much below the late 20s to start. And again, if you're conscientious about it, you don't really want to addict your patient to it. You have to use an intelligent approach.
Definitely. Now, I'm reminding everyone you're listening to Healthy, Strong, and Active, Your Strategy to Life. My guest is a pioneer in dermatology and in the practice of dermatology and cosmetic dermatological use, so to speak. And we're continuing this conversation. We've spoken about melanoma. We've spoken about Botox. We've spoken about various topics. And one thing we haven't spoken about, which I'd like to speak about as a specialist, to see what effect the insurance companies have had on you. Most of these procedures are not covered by insurance, and of the ones that are, obviously, if you have melanoma and you have to go for screenings, that's obvious. But there are obviously some problems in patients that have certainly Obamacare. And I'd like to know, there's been a movement for basically private practice to be moved into the hospital systems. And so that has not been really great for patients. But I really want to find out, what impact does that have on your practice as a specialist? Because we have to have access to specialists, and it seems to me we're not going to get the appropriate access, or maybe not even some of the care that we should get from specialists that are highly trained in this area. So give me some thoughts on that.
Well, you bring up a very important subject about Obamacare, health insurance, and so forth. And by the way, it's really very interesting that patients who will want to go to somebody in a managed care network, so it costs them no more money than their co-insurance, will seek a cancer surgeon, for example, who will be a network doctor and not cost them money. But the same patient will often not think a second thought about spending thousands of dollars for cosmetic services. And I couldn't understand. I would say that patients are much more grateful if you can make them look better than if you save their lives. It's a funny thing, but I see it all the time. There was a formerly fatal skin disease called pemphigus, and I was one of the co-authors in a leading article of the New England Journal of Medicine years ago, where we proved that this was an autoimmune disease. We gave a new way of treating it, and yet anybody that I treated for pemphigus always resented having to pay for the treatment. But I had certain people, you give them a little collagen, you become their hero for life. They make parties in your honor, and the reason is that people enjoy looking better, and they're afraid of dying. But the way Obamacare has impacted is that the good part of it is it's given health insurance to many people who previously were uninsured. The bad part of it is it's caused the cancellation of health insurance for millions of people, and even those people where it's not caused cancellation, like myself, it's raised the cost of insurance tremendously. And at the same time, if you had insurance for a while, when you go to a drugstore to fill a prescription, the insurance company will often try to deny the prescription for you, and then you have to get pre-approval. You have to go through a whole series of aggravating steps to get the prescription your doctor is writing for you. And by that same token, the cost of drugs, even generic drugs, has skyrocketed beyond anything. There's a particular lotion that I write for a lot called Cordran Lotion. And when I was a teenager, a 2-ounce bottle of that would cost $13 or $19. Today, the same bottle, no research development costs, only really a slight change in the label, the same bottle costs $300. And unfortunately, there are many people who have to choose between getting their medicine and buying food. And even with Medicare and Obamacare, there's a big donut. And I think that's a really terrible problem that people have to face. Now, at the same time, hospitals have been buying private practices, as you say, and been bringing doctors into their practice. Now, as we mentioned earlier, the advances in treatment, not only in things like cancer but heart disease, have become phenomenal. And people who would have a few short years ago died of heart disease, say if they have a bad aortic valve, can now, if they're older and sick, can get something called transcatheter aortic valve replacement. So millions of people are being saved every year. But unfortunately, healthcare has changed from a profession into a business. And hospitals speak about getting bigger market shares, and they look at other hospitals as competition. When I was in training, hospitals used to cooperate with one another. To me, one of the worst things is if a physician is employed by a hospital. Many hospitals will set income goals for that physician. And if the physician is not generating enough income in the sense of recommending laboratory tests or recommending x-rays or seeing enough patients, the business people, the MBAs in the hospital, and this is true in almost every hospital, will go to the doctor and say, you're not generating enough income, we're going to have to cut your salary, or you're going to have to see more patients. But the worst thing is when people are employed by a hospital, many hospitals require that all referrals be made to other physicians within the full-time network of doctors employed by that hospital. Now, for example, if you come to me and you have a particular problem, and I think that there may be some doctor at NYU or Cornell or Columbia or Mass General, I can send you any place that I think you're going to have the best care. But if I'm employed by the hospital, I have to find somebody within that hospital to treat you to keep your income stream. And of course, all good hospitals have excellent people in every field, and you'll still get good care, but it may not be the optimum care. So that's one thing that you give up by going to these hospital physicians. The other thing is most physicians in private practice are reachable basically 24 hours a day through their answering services. And most of us have developed long-lasting relationships with our doctors, where our doctors are not only our physicians, but they become our friends. But with the new trends, if you want to call your doctor after 5 o'clock, you're out of luck. You may have to go to the emergency room where you sit around and wait, or there may be some walk-in clinics, but you're not able to get your doctor. And when you're admitted to the hospital, your care is often done by a hospitalist who doesn't know you. And if a doctor doesn't know you, he may not know, even though he has a great electronic record of everything you've ever taken in your whole life, he doesn't know how you really respond. And that's a big thing that we're losing. The other thing,
I think you said a mouthful here.
I just want to say one more thing.
Recapping what you've said, and rightly so, is that the hospitals are becoming mini monopolies, and they're paying these physicians more to work in these hospital systems. So that's one thing, and so as a result of that, it becomes an issue. There's an ethical issue in a respect also in treating these patients. Okay, especially for example, Medicare patients, what they'll receive receive, if you have just Medicare and you're going to one of these physicians, they'll receive more reimbursement being in one of these hospital systems than they would if they weren't in one of these hospital systems. So there's a financial incentive for them to take Medicare while they're part of one of these systems. Private practice would start to go extinct because they're not going to get the same remuneration from the government. They're pushing for these programs. In addition to that, you touched upon this thing. If, for example, I would always write, no generics, please, on my prescriptions, medically necessary. And, of course, there's financial constraints. They're not allowing that to happen. But the patient needs to understand, and they need to have a conversation with their physician, that when something's prescribed, there's a reason. Because there are now bootleg medications that are coming out that look perfect, that are less money, even name brand medications, or they may want you to go to an outside source to purchase your medications, maybe Canada or maybe wherever it may be. And these may have ingredients, and my personal preference is that these generics, on rare exception, do not perform the same as what you prescribe and of the medication's active ingredients to get a prescribed effect. And I'm sure you've observed the same thing.
You've made some very good points. First of all, if a patient with Medicare goes to a hospital-employed physician instead of me, Medicare will actually pay for that visit 3 times the amount that they'll pay if the patient comes to see me. And I think that's costing the government a lot of money, and I think it gives the hospitals, as you pointed out, a great incentive to have those visits and to utilize their services in a way that may not always be necessary. Now, when you speak about generics, many people take Lipitor or other cholesterol-controlling drugs. Most physicians, for themselves, will pay the extra money and get brand-name medications. There are exceptions to it, but on the whole, that's true. Twice it happened that the generic form of Lipitor made by a very large Indian company was found to contain particles of glass. Also, when we say they're the generic equivalents, they're not truly equivalent because they're allowed a 10% deviation on both the upper and lower limits of effectiveness. So you may think you're getting an equivalent, but really you're getting something where there could be a 20% variation. Now, before you were speaking about injectables and Botox, and I would tell your patients to make sure that their physicians are buying their Botox and their injectables directly from the manufacturing source, because every day I get offers to buy Botox from Canada or Turkey or Ireland or so forth, and recently articles have appeared showing that the FDA has identified counterfeit versions of Botox and fillers in many doctors' offices across the country. So if your doctor is not buying it directly from the manufacturer, you really have no idea at all about what you're getting. So ask him if he does buy it directly from the manufacturer or through some third-party source, because counterfeit drugs have become a huge and very dangerous problem.
Well, in keeping with that, there's another thing, thought to think about. I mean, again, I think it's important that when you have this discussion with the patient as to the use of generics and where you get them, but surprisingly so, I know most people will go to a Walgreens, a CVS, or somewhere like that, and that's fine because they're contracted with these groups. But they should really have a relationship with a pharmacist and a small pharmacist who really knows where these products are coming from, not necessarily in bulk. And you could feel also very certain that the product that they're getting is within the best interest of the patient. Do you have some experience working with really local pharmacies?
I encourage, as you do, all of my patients to try to go to local pharmacies, because these poor guys are really being squeezed out by these giant multi-billion-dollar corporations. And everybody is trying to make a living, including your local pharmacist. But if you know anybody who's worked for any large corporation, you know the pressure on the corporation, particularly if it's a publicly listed corporation, to always show better results every quarter. And just because a corporation is big doesn't mean that it's necessarily ethical. In fact, I'm sure many of your readers have dealt with large corporations and have found them to be unethical. Look how many deaths resulted from defects in manufacturing from General Motors cars, how many billions of dollars they've had to pay out. And recently, the court has ruled that because GM went bankrupt, that they're under no obligation at this point to take care of a lot of the problems that arose before the bankruptcy. The emphasis on corporations, and I'm a capitalist, I believe in the capitalist system, but the emphasis on corporations goes only to the bottom line, and that's what they care about more than anything else. There are many ethical companies, but in the end, they have to make their shareholders happy, and they have to pay for the private jets of their CEOs.
Well, it's hopeful. This country is built, unfortunately, the medical system is broken, and it's broken, and it's a topic I've covered, but it's broken because we are a system of procedural intervention. We're not a system of preventive intervention. And the only way that the system is going to change is when the government starts remunerating physicians for working with preventive care, because that's going to save lives in the end. If our interest is only in cutting and high-priced procedures, then what will happen is the system will never change. It will continue to go bankrupt.
Well, there's another aspect, too. Look how many insurance companies give major donations to politicians who will favor legislation that helps their agenda. And while the politicians decry how much money doctors are making and hospital executives decry that too, the presidents of many of these corporations see themselves as running billion-dollar enterprises and therefore see themselves as being entitled to the compensation of an executive in any billion-dollar corporation. So look at the stock prices of health insurance companies, how they skyrocketed. Look at the salaries paid to the CEOs of these insurance companies, and look how much these salaries come out of the benefits paid to their policyholders. They're very anxious to collect premiums. They're not that anxious to pay out benefits.
No question about it, and no question. Well, again, the hour, I promised you now, I know you've got a busy practice. I want to sum up by saying a couple of things. First of all, that on this show, I think it was very important. I think if you were listening and you didn't know, you know now that, number one, self-examination is so important because with melanoma on the rise and affecting women, number one, and behind breast cancer as well, and young men as well, and blacks and Hispanics, everywhere, where no one's immune to it. And the fact is, it's growing at 3% a year, almost 8,000 deaths a year. And all you have to do is to do a self-examination once a month. And at least once a year, go to a dermatologist, a certified dermatologist, who can examine your body and all areas of your body so that it's documented if something unusual is there. Just by doing that, you can lower your risks by 60%. And that's an important take-home message. In addition to that, it's been such a delight to have Dr. Albert Lefkovits, who is a pioneer in the field of dermatology, who's got offices on Park Avenue. I want to give a plug to your office, Albert. Can you give me the address of your office?
It's 1040 Park Avenue, which is the northwest corner of Park Avenue and 86th Street.
I mean, which is great. You've been an absolute delight, so informative, and people who want to learn more about Botox, there is no better place in the world than by yourself. And again, seeking out people information. I think your offices have been delighted. I've had an opportunity to go to your office myself, and I wasn't there as a patient, but I observed what I had seen. It's a wonderful facility, and everybody was extremely happy with the services there. So I want to tell you, I appreciate so much you being on the show. I can envision actually having you on a show again because there's a lot of topics that we haven't touched upon. Keep in mind there's infectious disease. We haven't spoken about that. There are other aspects in dermatology that people would really find extremely fascinating and interesting and learn from. So with that, again, I want to thank you so much for being on the show, and I invite you to come back again.
Well, thank you very much. You've been most kind and gracious in your remarks. I've enjoyed speaking with you, and I think you've asked really important questions of great significance to your listeners.
Thank you very much.
Thanks for listening to Healthy, Strong, and Active. If you have questions about this program or any of the topics that we've covered here, please feel free to call Dr. Katzman directly at drk@healthystrongactive.ws.